Good morning, good afternoon, and even good evening to some of you, and welcome to this event on COVID-19, Magnifying the World's Inequities. I'm Sarah Barnes, and I'll be moderating our discussion today. I direct the Maternal Health Initiative, and I'm also the Women and Gender Advisor at the Wilson Center in Washington, D.C. For those of you who are unfamiliar with the Wilson Center, the Woodrow Wilson International Center for Scholars was chartered by Congress more than 50 years ago as a living memorial to President Woodrow Wilson. The Wilson Center is a critical source of nonpartisan foreign policy research and analysis in Washington and serves a vital role in linking Washington to the world. The Maternal Health Initiative is one of several thematic programs at the center, and we focus on decreasing maternal deaths as well as issues related to global health and gender equity. COVID-19 has truly magnified the world's inequities, and today I will speak with several global health and gender experts about these inequities as well as their solutions. Thank you to all of our panelists for being here with us today. I would also like to thank EMD Serrano, a business of Merck KGaA Darmstadt, Germany, for their partnership and generous support, which has made this event possible. And also, I would like to take a moment to thank all of the programs at the Wilson Center for co-sponsoring this event. As a result of their partnership, we had almost 1,300 RSVPs from across the globe and a unified voice to the importance of these topics. To learn more about what particular Wilson Center programs are doing related to the coronavirus, please visit the Wilson Center website at www.wilsoncenter.org and click on Coronavirus under the Topics tab. Confirmed cases of COVID-19 have surpassed 3 million, and more than 200,000 people have died across the globe. While COVID-19 has wreaked havoc the world over, history has proven, and recent data agrees, that the hardest hit will be the world's women and girls and populations already impacted by racism and discrimination. Coronavirus hurts women and girls beyond infection. Access to maternal and reproductive health services have been disrupted and deprioritized. Healthcare workers and caregivers, who are mostly women, are jeopardizing their own health, caring for others. Women have been pushed back into the home and girls have been pushed out of school, both of which will have lasting effects. And the world is seeing an increase in the incidence of gender-based violence. Discussions of gender should also include the experiences of men and boys, and we will be sure to include them today. Early numbers show men being infected and killed at higher rates than women from COVID-19, with gender experts pointing to social norms and masculinity as possible attributors. Lack of reproductive health service and being essential workers during a pandemic also affects men. And since men are ultimately responsible for the increase in gender-based violence, men need to be included in discussions of gender and solutions. Racial inequities also heighten the risk of contracting and dying from COVID-19 for men and women of color. At the start of the month, data showed that Black and Latino residents of New York City were dying from COVID-19 at twice the rate of white residents. In Washington, D.C., African Americans make up 46% of the population, and this week, Mayor Bowser released data showing that 80% of the total COVID-19 deaths in D.C. are among the African American population. Singapore went from being considered a gold standard for its response and containment of the virus to having one of the worst outbreaks in Southeast Asia because of the treatment of migrant South Asian workers who face racism and discrimination in the country and are forced to quarantine in cramped migrant dorms. I'm eager to tackle these global issues and more with our panel today. Those watching online, you can also participate in the discussion by sending us questions for the panelists. Please send questions to mhi@wilsoncenter.org. Include your name and affiliation with your question. You can also follow the conversation on Twitter with the hashtag MHDialogue. Again, if you want to send questions, please send them to mhi@wilsoncenter.org. And now, to start things off, I would like to introduce Dr. Maria Rivas to give opening remarks. Dr. Rivas is the Chief Medical Officer at Merck KGaA Darmstadt, Germany, and the Senior Vice President of EMD Serrano. Merck KGaA Darmstadt, Germany is 350 years old, making it one of the oldest pharmaceutical companies in the world. Maria and her team are responsible for translating the company's science and innovation into improved patient care, and she has been a pharmaceutical executive for over 20 years. The Wilson Center has had the pleasure of partnering with EMD Serrano for 3 years, tackling issues around women's health, gender equity, and caregiving. The floor is yours, Maria.
Thank you, Sarah. And again, a warm welcome to everybody who's joined this very vital and timely webcast. I'm really honored to give the introductory remarks for such a distinguished panel today to talk about, on behalf of the Wilson Center, as well as others, the impact of gender inequities, the impact that COVID rather is having on gender and other individuals that are disadvantaged. And it's quite frankly a topic that is very relevant for us in the pharmaceutical environment. As you've probably heard around the world in the news, the pharmaceutical companies are very busy right now trying to partner with governments and other health authorities to try to find as fast as possible some treatments, vaccines, and diagnostics. I'm also happy to say that pharmaceuticals such as Merck also have been involved for a long time in trying to be part of the solution about gender inequities and other inequities in healthcare. At Merck, we have a long-standing commitment to make sure that we look at the women as a vital health economic contributor. And as caring or caregiving is unfortunately remarkably heavily a burden for most women, more women than men. 70% of global caregiving hours are provided by women and girls. We have particularly partnered with government and health authorities to launch a particular program called Embracing Carers to try to make sure that we dedicate increasing awareness and discussion about the overlooked essential needs of caregivers, and particularly in the context of this pandemic. We can imagine that, as the UN Secretary has said, the pandemic is having essentially an inordinate or imbalanced impact, a particular heavier burden on women and girls. And in addition, our company, Merck, is also very proud to be a private sector leader for another initiative called the Healthy Women, Healthy Economies, which promotes national policies that improve women's health for greater economic participation. I believe that this crisis, if anything, we should try to grapple it with the COVID-19 pandemic and turn this crisis into an opportunity to try to identify and implement innovative solutions that transform the world of caregiving and promote gender equality at home and in the workplace. So again, I'm looking forward to a very vital dialogue today with all participants and presenters, and to really learn what are best practices, what are recommendations that we can hopefully take further beyond this pandemic. Thank you very much, Sarah. It's a pleasure.
Thank you, Maria, and thank you for those great opening remarks and your partnership. So now I would like to move things on to our panelists, and I'm going to introduce them one by one with a question on gender-related inequities and solutions due to COVID-19. And we're going to start with Katja Iverson. Katja is the president and CEO of Women Deliver, a leading global advocate for investment in gender equality in the health and rights of women and girls, with a specific focus on maternal, sexual, and reproductive health and rights. Katja, an internationally recognized expert on development, advocacy, and communications, has more than 25 years experience working in NGOs, corporations, and United Nations agencies. Welcome, Katja. Women Deliver put out a report straight away on the importance of women's leadership in using a gender lens during the pandemic response. Can you speak to these important issues as they relate to COVID-19?
Thank you very much. I think I'm on now. Thanks, Sarah, and thanks, Maria, for a great introduction, and to everybody here. Yes, Sarah, as you said in your introduction, mortality of men is higher, but let me just emphasize that women play an outsized role in responding not only to COVID-19, but in many of the pandemics. In fact, evidence shows that disease outbreaks affect women and men differently, and that pandemics exacerbate gender and racial inequalities. We heard the numbers. Women account for 70% of the global healthcare workforce and the vast majority of social workers. They're also still the caregivers at home and mobilizers in their communities. We also know that people still have sex, need contraception during a pandemic. Women still get pregnant, wanted or unwanted, and still give birth. And they still have that human right to health. As this crisis intensifies around the world, because I don't think we've seen even the worst of it yet, even if it has been really bad, it is clear that if we want to deliver health, well-being, and dignity for all, we really need to apply that strong gender lens to preparedness, response, and recovery, both to guarantee the unique needs of girls and women, but also to address the unique expertise, that the unique expertise is leveraged. And this includes positioning girls, women, and young people in all their diversity and in all settings, front and center in the emergency response, in the social and economic recovery efforts, and in how we strengthen our health systems for the long term. So just a little scene setting, there's good news and there's bad news. On the normative side, things have been going pretty well. We at Women Deliver and many partners have worked hard to get the big wigs and the big systems to apply a gender lens to COVID-19 response and recovery, also so we can lay down tracks to build a more gender equal world and use the opportunity to dismantle some of the barriers that we have seen. A couple of examples. We have worked with the Secretary General of the United Nations and his team, fed into a policy brief on COVID-19 and women. Also, he did a very strong message on gender-based violence. We've nudged, we fed, we amplified, and this brief has gone further and been developed into action-oriented tools for countries and institutions and organizations to really to keep gender at the center of plans, and with sexual and reproductive health and rights included. We've also helped mobilize hundreds of civil society organizations in the Deliver for Good campaign to push a gender lens. So far, 600 organizations from around the globe has signed on to the Deliver for Good call to action. You'll hear a little bit more about it later. And we also helped mobilize the G7 Gender Equality Council members that, includes both celebrities and Nobel Prize winners to really push the big countries on this. So we work with the big funds because money talks, and we need the big investments to include a gender lens and a gender marker. And we have seen that included successfully also in the new UN framework that is kind of informing countries across the globe. So we are hearing that 150 countries have included consideration about gender-based violence in their responses, and some are applying that bigger, broader gender lens now. So in that sense, things are moving. But yes, at the same time, we are getting the news from around the world about the surge in domestic violence, in poverty, in inequality. We're seeing that gender roles regarding the unpaid care work, the work at home, is going backwards, and that millions and millions of women are losing access to contraception, and we're expecting an avalanche in unwanted pregnancies. And with that also comes maternal death. We'll hear more about that later. So it truly, truly is a mixed bag. At Women Deliver, we have developed 10 recommendations to build a stronger and more gender equal world in regard to what we can do now, what we need to focus on now in COVID. And they'll be coming not out next week, but just kind of giving you a sneak peek. It's kind of get that gender lens out and apply the gender marker for tracking so that we can keep girls and women at the center of the response and recovery. We also need to make sure that women and young people are included as leaders in the response. No decision should be made about them without them. And that goes in the leadership and in the everyday work. And I know Rupa would speak more about that. And last but not least, we need to safeguard and protect maternal, sexual, and reproductive health and rights and women's essential care. If we're not careful, we will lose tremendous ground and potentially even more lives than COVID can cost. On that, maternal, sexual, and reproductive health and rights, it is essential care. We have to have it included in that. It's more essential than ever that we protect it, both because we risk money being diverted away from this. We've seen that in the other pandemics. We saw it in Ebola. Both the money and the healthcare worker were taken from the maternity ward, from the reproductive health, and that cost so many lives. But also because we know that dark forces are trying to use the situation to take our rights, our reproductive rights away. If we are not careful, we're going to lose a lot of ground. We've already seen an increase in the gender-based violence, as we heard. We've seen access to abortion being classified as non-essential and being made available to the women who need it. And we are seeing across the globe resources on the edge of being taken away from maternal health and SRHR. But we will not stay quiet. We cannot abandon the gains. So we need to be smart. And that is also why I'm asking everybody here, my co-panelists, but also everybody who's tuning in, use your power individually and institutionally to keep women at the center and apply the gender lens.
Thank you, Katja. Thank you very much for those inspiring and opening remarks. And you've actually set up our next speaker, Zara Ahmed, quite well. Zara is the Associate Director for Federal Issues at the Guttmacher Institute. She joined the Institute in September 2019 after 10 years with the CDC, including 7 years spent in Rwanda, Namibia, and Haiti, and 3 years as the Associate Director for Policy and Communications for the Division of Global Health Protection. Zara, Guttmacher Institute has put out some incredible statistics about what limiting access to sexual and reproductive health services will mean for women during and after this pandemic. Welcome, and please, the floor is yours.
Great. Thanks so much for having me and for this question. In the midst of this pandemic, bad policies and structural barriers may contribute to millions of people losing access to essential sexual and reproductive health services. Our team at the Guttmacher Institute estimated how sexual and reproductive health outcomes could change following only a modest 10% decline in access to care in 132 low and middle income countries, which together include over 1.6 billion women of reproductive age. The implications are staggering in terms of the needs left unmet, unintended pregnancies, unsafe abortions, and maternal and newborn deaths. Over the course of a single year, a 10% decrease in sexual and reproductive health services in low and middle income countries would lead to 49 million more women with an unmet need for contraception, 15 million more unintended pregnancies, 168,000 more newborn deaths, 28,000 more maternal deaths, and we could see 3 million more unsafe abortions and 1,000 more maternal deaths if just 10% of safe abortions are compromised. Now, these estimates are shocking, but the reality could be much, much worse if more than 10% of services are compromised or disrupted. In addition, the scale of the impact could be many times greater in specific countries or regions or populations, as the virus and the lack of effective response has and will hit certain populations and areas harder. And this is on top of the vast pre-existing need. For example, before the pandemic, there were already almost 220 million women who wanted to prevent a pregnancy, but were not using a modern form of contraception. 220 million. That's far more than the entire population of Western Europe combined. Now, there's still time to act, but policymakers have to move quickly to avert this catastrophe, and they should prioritize 5 key actions. First, as Katya said, they must define and promote sexual and reproductive health care, including safe abortion, contraception, and maternal and newborn care as essential. This would allow people to travel for sexual and reproductive health services, even in areas under stay-at-home orders or with travel restrictions, without fear of legal consequence. Second, alongside private sector actors, they must shore up and strengthen the national and regional supply chains to make sexual and reproductive health medicines and supplies more accessible to both patients and providers. Third, they must make contraception available without a prescription, decentralize distribution, and facilitate multi-month dispensing of sexual and reproductive health pharmaceuticals. We have to make contraception available to people when they want it and where they want it. Fourth, we must adopt innovative models of care, including telehealth, as well as prevent diversion of resources and staff away from sexual and reproductive health care. And finally, and this is at the heart of our discussion today, they must address the unique needs of vulnerable and marginalized populations, including those living in humanitarian settings, as they're contending with barriers that are already being exacerbated by the pandemic. Now, these recommendations apply to policymakers in all countries, both for programs within their borders, as well as their work with partner governments overseas. As the largest donor for sexual and reproductive health programs globally, the United States has a special, significant role to play in preventing this looming disaster. And we have 2 key recommendations for the US. So first is to enable health facilities to provide all necessary services, Congress should pass the Global Health Empowerment and Rights Act, known as the Global HER Act, to reverse the harmful global gag rule, as that rule inhibits partners overseas from offering people comprehensive sexual and reproductive health services, including during the crisis. We have a brand new policy analysis up on the Guttmacher website that delves into this further. Second, Congress should increase funding to global programs, including funding for UNFPA, and support policies that alleviate pressure on health systems, expand access to sexual and reproductive health globally, and promote gender equality. I'll end by saying that outbreaks are inevitable, but catastrophic losses for sexual and reproductive health are not. By learning from prior epidemics, putting in place critical resources and systems, and promoting sexual and reproductive health and rights, we can prevent health system disruptions that would have devastating, lasting consequences on individuals, families, and the global community, particularly for the most vulnerable among us.
Thank you, Zara. You've shared some really startling statistics, and I really appreciate you giving those 5 asks to policymakers. That's really helpful to our conversation. Thank you. So now I would like to move to Layla Sharafa. Layla Sharafi is the Senior Gender Advisor at the United Nations Population Fund, based at the organization's headquarters in New York City. She's responsible for coordinating the organization's gender mainstreaming efforts and managing global gender and human rights programs, including those related to women's and girls' empowerment, engaging men and boys for gender equality, as well as promoting the rights of adolescents and youth. Layla, UNFPA has also put out several reports since the start of this pandemic on the gender lens, gender equity, and gender-based violence, recently projecting that a 6-month lockdown could lead to an additional 31 million cases of gender-based violence. Can you elaborate on these gender issues, including the role of men and boys?
Great, thank you so much, Sarah, and thank you for having me. As the previous speakers have talked about, pandemics magnify existing inequalities. And while the virus doesn't discriminate, its impacts do. And I think, as Dr. Rivas talked about in the beginning, and Sarah, as well as Zara and Katya, we know that data is showing us that men and boys may be affected disproportionately in terms of mortality from COVID-19. The impacts in terms of social and economic impacts are really devastating on women and girls, and I think we've noted that. But just to say that, given that 70% of them are in the healthcare workforce, given that many of them are essential workers, given that they are taking on the disproportionate care burden, it's a concern. In terms of gender-based violence, we're seeing an increase, and this is because of isolation, lockdown, restricted movements, tensions in the households from financial and economic stresses. So we're really experiencing an increase, unfortunately, particularly of domestic violence. Now, before the pandemic, global estimates were that 1 in 3 women faced some kind of violence, gender-based violence. Well, now we're seeing, and again, early data showing us that this could be increasing anywhere from 20 to 35%. And reports are coming from countries in every region. So this is an issue that is being experienced everywhere, and it's not limited to any one particular place. So reports from France, from Spain, from Malaysia, from South Africa, US, UK, the list goes on really. And it's really something that is striking. Although we know that in crisis situations, violence does increase, it's still very stark to see those numbers come in. And Sarah, as you mentioned, UNFPA published projections earlier this week, and as you noted, for every 3 months of lockdown, we can see a projection of 15 million cases of increased gender-based violence and 30 million for, let's say, 6 months of a lockdown. UNFPA, along with other UN partners, are working with national partners to support responding to this, but also being prepared, particularly in places where the pandemic hasn't hit so hard yet. And there are things you can do to really be ready. These issues are very complex, but there are things that we know and lessons that we're learning in terms of being ready. Number one, we have to ensure that we advocate, and I think as Katja also noted, that there be an increase in funding and be ready to increase funding for protection of women and girls, knowing that violence will increase. So the unfortunate situation is that the crisis comes, we know violence will increase at the very same time that services, resources, and attention are diverted. So there's that double kind of slam, right? So there has to be increased resources, number one. Now this is challenging in resource-constrained environments, absolutely. But thinking about sort of the investment and where that goes in the response and preparedness is critical. Number two, and I think the most important, is to ensure that your services are adapted, they're flexible, and that the referral pathways for women and girl survivors are updated, and that the community and those women and girls who would need to access those services are aware of those updates, right? So where to access services as the pandemic hits, and let's say they're in lockdown or situations of quarantine. So among the things that we need to ensure in terms of services is what you would normally need to do in any situation, right? Multi-sectoral services to ensure that women and girls are safe and secure. But that includes, in this particular situation, making sure that places where women and their children can be safe are deemed essential services so that they remain open. And this isn't necessarily happening everywhere. You want to make sure that you have surge capacity to deal with the healthcare response, but also helplines, shelters, repurposing potentially shelters, hotels if you need to, of course, with the safety and risk management in mind. So ensuring that you're shoring up the capacity for these services. Psychosocial support will be critical alongside health sector response, not only for the survivors, but also for frontline health workers. And we're seeing that as coming up as a real concern as healthcare workers, and many of them are women, are subjected to a lot of this trauma, essentially. The second thing in terms of response is, the third thing in terms of response is making sure that the police and the judiciary are aware, and this is part of the multi-sectoral response, are aware that there's going to be an increase in violence, but also making sure that access to justice doesn't come to a standstill just because there's a quarantine or lockdown situation. We need to make sure that protection orders are extended or are still granted during this period of time, which again is ever more important given the increase in violence and tensions. And of course, you also need to work with women's rights organizations and civil society. They're really the ones at the ground level in the communities who know the women, who know how to reach them, and who can really support the process in terms of finding the right way to set up these updated referral pathways, et cetera. We're also seeing really interesting, innovative things take place as well. For example, in France and Spain, and UNFPA support in Argentina is helping enable this, but enabling pharmacies as places where women can access services or at least get help, initial help, using a code word if they're accompanied by their partner, for example. So these are the kinds of things that I think we're starting to see and lessons come up that can help inform others to get prepared. And finally, I'll just close by saying, absolutely, we need to ensure that we have data collected about the cases as we're learning, but also ensuring that data is maintained as confidential and anonymous, which is for the safety and security of women. And I can't say enough about engaging men and boys to address harmful masculinities and social norms that underpin their health-seeking behavior, which may also be impacting the higher mortality rates for men, but at the same time, also that underpin some of the violent behaviors that we may be also seeing. But that is also part of the long-term response and solution. Thank you.
Incredible. Thank you so much, Layla, for your commentary and your suggestions for the response. Now we're going to move to talk a bit about maternal health and pregnancy. And we've got two great speakers to talk to these issues. And first, I am going to welcome Dr. Joya Adele Crier-Perry. Dr. Joya is the founder and president of the National Birth Equity Collaborative. She is a thought leader around racism and racism as a cause of health inequities, and an advocate and policy expert on improving national and international maternal and child health outcomes. Dr. Crier-Perry, Black Maternal Health Week was earlier this month. Can you speak to us about socializing respectful maternity care and how COVID-19 is playing out in regards to disrespectful care?
Well, thank you so much, Sarah, and thank you to the Wilson Center for having me here today. So I just want to talk a little bit about what racism actually means first, because I think usually when people hear the word racism, they think I'm calling them a bad name or it's a slur. And really, we have to really grapple with the truth that we have a historic and a current belief of a hierarchy of human value based upon skin color. So when I say hierarchy, that means that there's a range. So that means that there's Asian people that people believe are in a different area, and there's gender norms. So it's a range of the belief, right? But this belief has existed for about 400 to 500 years, and it's promulgated around the world. We've created laws and rules around it. I mean, when I was in medical school in the late 1990s, I was taught in embryology that there were three races: Mongoloid, Caucasoid, and Negroid. And so those three races made health disparities innate by our genes and by our DNA, because that's what the belief system was. So Black folks have known about fake news for a long time. So we've had this 500-year experiment in this belief of a hierarchy based upon your skin color that plays out in our health systems and how we deal with what happens inside of hospitals and everywhere else. So for about 10 years, 15 years, we've understood what social determinants of health are. We've had this idea across the world that it wasn't your genes or your choices, but really things like access to food, access to clean water. Those things determine your health. What we haven't talked about in a global conversation is how did we get these social determinants? They didn't just fall out of the sky, right? We don't have just magically differences between who has access to food and water, or who has access to insurance based upon our skin color. That didn't just happen, right? So we have three main root causes, and those are racism, classism, and gender oppression. And so we have a lot, and those oppressions love each other. So when they show up in different contexts, so if you're in another context, it might be casteism. It might be religious fundamentalism, especially if in a place like Louisiana, where I'm from, right? So other oppressions find ways to build on that. But we do know that Black women in the United States, despite income or education, are still more likely to die in childbirth than their white counterparts. So that's really where you see the overarching, how those inequities and those beliefs around hierarchy can come together in one space and cause people to die. So if I show up as a Black woman, even though I might have a PhD or an MD to your hospital, what you still see me as is someone who's not valuable. That's come from our textbooks, from the founding of our field of obstetrics and gynecology, right? So there's this belief that certain groups are here for us to experiment upon, to use. You see even now, there are hospitals and nursing homes in the United States that are giving people medications that they haven't even tested to say that they work, because we still believe we can experiment and try things on people who we don't value. So respectful maternity care has been around, and thanks to our colleagues at the WHO and the White Women Alliance around the world for a while, for about 10 or 15 years as well. But we haven't really socialized this idea in the United States. No one has an expectation of being treated with respect. We don't even know what that means. We just go to the hospital and hope we can survive. And that idea that we are not, you don't understand or don't have a framework for respectful maternity care, an expectation that our wishes and our desires should be met, that we should be fully heard, that we should have trust between the provider and the system. Those things haven't happened. And we're working with our colleagues at the American College of OBGYN and at Johns Hopkins to really build that out and to really socialize that in the United States so we can have a workforce that actually values the people that it's working with and sees them as partners in their care and not someone over which they must tell what to do, kind of this patriarchal hierarchy belief around how healthcare works. And when we don't acknowledge that the United States is part of a global phenomenon, that when we do global maternity work and then we do US work, as if the two, like the US is not inside the globe. I've never quite understood that, because when you go to those meetings, like I have the great opportunity to do, it's the same issues. Patriarchy, religious oppression, it's all the same things we have here as well. So when we export US ideas, like we can have the global gag rule that happens globally, that comes back to the United States in the same way, because we haven't acknowledged it's the same belief systems that are causing both things to occur. And so having respectful maternity care globally is important for us, and to undo those overarching things. We do things when we export US healthcare systems, you see things happen like C-section rates in India go up really high, because not only do we export our technology, we export our patriarchy and our white supremacy. And so people just show up in hospitals and they're not valued about what their wishes are. So we have to deconstruct the things in the US and globally for us to have value. And so lastly, I love being a part of the reproductive justice movement. As a board member of the Black Mamas Matter Alliance, we really are really focused on undoing kind of this belief that it's just, as a healthcare provider, I provide services. And when you do reproductive rights, we look at the laws and the rules, which are really important. But we see right now, people's rights are being taken away. People's rights are not being serviced. So when you have justice, you have a movement, you have an opportunity to build on not just having access to care and to health, but how do we organize and undo these root causes of things like racism, classism, and gender oppression? So that's it.
Thank you, Joya, for your remarks. I'm sure we'll be coming back to more discussion on this in a little bit. For now, we're going to continue on, and we're going to turn to Dr. Neil Shaw. Dr. Neil Shaw is an obstetrician and gynecologist and professor at Harvard Medical School, and is currently providing reproductive health services and delivering babies amid the COVID-19 surge in Boston. As a public advocate and global expert in health system design, he co-founded the March for Moms Association and serves on several boards, including the Office of Women's Health Research at the National Institutes of Health. Neil, welcome. You're an OBGYN working during the pandemic. Can you talk to us a little bit about what you're seeing as you continue to treat patients in Boston?
Sure, Sarah, thank you. And thank you to all the incredible panelists with whom I've already learned so much from in a short period of time. I am practicing at a tertiary center in Boston right now. This is the week that cases are surging in my city. And we serve the greater Boston area, including the city of Chelsea, which has some of the hardest hit neighborhoods in our entire state. When I'm not in the hospital, I lead a research and social impact program that really has two lines of work. One aims to support hospitals and healthcare systems, and the other aims to support communities. And as I consider my own experiences, and as I look out across the health systems and communities that we're trying to serve, what I see is that the divide between those that are aiming to provide care and those that are in need of care has never felt wider. And I want to really focus my comments on why that's the case, how critical it is to repair it, and how with humility and empathy and innovation, we can fix it. This week, about 2 days ago, I spent the night in my hospital where I helped take care of people in labor, attend to emergencies, and answer phone calls from scared people at home. And one of the things about this virus that's different from really anything we've ever seen. I mean, all viruses exploit our behavior in order to spread, but COVID-19 really preys on our instinctive need to be with each other during times of suffering. And that desire is exactly what makes it so deadly. It's a virus that spreads silently and visibly within people and across people. It geometrically multiplies with this imperceptible slowness while building in strength. And compared to other humanitarian disasters where you can see the suffering or at least the threat visibly and acutely, even compared to Ebola, where the people that we had to isolate were acutely symptomatic, this is different because of its invisibility as it's spreading and its slowness. Currently, we have to isolate people who are both symptomatic and asymptomatic, which is effectively everyone. And isolating everyone takes all of the existing inequities in our society and it throws them into a pressure cooker. And we're seeing the impacts on pregnant people prenatally during labor and as they're home caring for their infants without very much support. 2 days ago, and really every week, I'm answering phone calls from scared pregnant people at home who are symptomatic. And one of the challenges that I'm seeing right now is that the biology of this disease and the sociology of this disease really interact. And the people that are historically experts in the biology aren't fully attending to the sociology, and honestly, vice versa. So right now, if people are mildly symptomatic, we tell them, even if we strongly suspect that they have COVID-19, that they should continue to isolate at home. And one of the challenges with that is that the people who are most likely to get infected are the ones that are least likely to safely self-isolate in the first place. When people call me, I have a set of criteria that's entirely biological about whether or not they're at enough risk to come into the hospital, but it doesn't take into account their living circumstances. Chelsea is a community, the hardest hit community in our state, that's has a lot of Latino immigrants that are living in multi-generational homes. And if I were, honestly, they should probably be at the front of the line to get prioritized for testing. But we don't really take into account their living circumstances. It's also not clear how to do that, honestly, in a way that's sensitive and trauma informed. Should we
I think Neil has frozen. Neil, are you there? Okay, we're going to give Neil a minute to reconnect, and we'll come back to him because we definitely want to hear about his experiences in Boston. But for right now, what we'll do is we'll make a quick shift and move to Dr. Rupa Dutt. Dr. Rupa Dutt is the Executive Director of Women in Global Health, where she works with a network of women in global health chapters and supporters across 90+ countries in every region to challenge power and privilege for gender equity in health by supporting a diverse group of emerging women health leaders, engaging existing global health leaders to transform their own institutions, and by continuing to grow the global movement. Women in Global Health launched Operation 50 by 50 and 5 Asks for Health Security. Can you please speak about these initiatives and to the very real sacrifice, as Neil was beginning to speak to also, for the work of our health workforce, which is predominantly female?
Yes,
welcome, Rupa.
Great. Thank you, Sarah, and thank you to the Wilson Center for this conversation. And just building on what's really been said, I mean, this is really very much a conversation about COVID-19 has disrupted business as usual on a global scale. But at the same time, this global tragedy is really giving us an opportunity to reimagine the future. So as we talk about the challenges, really important that we're also thinking about how are we going to be building back better. So what really inspired Women in Global Health to approach COVID-19 and really look at the gender equality dimensions is some of those numbers we've already heard is that 70% of the health and social workforce are women. But when you take a look at senior roles, women only make up 25% of those roles. And if this is really, a war, as often spoken about, then we really contest that women are the frontline soldiers in this pandemic, and they really do have the expertise, and they should be at the decision-making table. Women, especially from the global south, are particularly underrepresented in global health decision-making. They make up less than 5% of the most senior roles in global health. There's also an effort to democratize and decolonize global health, and these principles are really critical as we think and reflect about really building back better. And women really are the experts. They know the solutions. They're leading the fight against in hospitals, health centers, care homes, labs, in parliaments. We've already heard and seen acknowledgement of how women leaders that are head of governments are approaching the COVID-19 response differently, showing much more collaboration, much more social cohesion, looking into social protections, less divisive politics. And when we raise gender equity and challenge COVID-19 decision-making bodies that are mainly male-led, that don't have women, we're often told now is not the time for special pleading on gender, or we are told there are no qualified women. And this is what really led to launching the Operation 50/50, which is a crowdsourcing list of women working in global health security. And within, in 2 weeks, we were able to get nearly 100 names of women all around the world. And now the list has grown to about 300 women, much more diverse, many more women of color from all around the world that have expertise to contribute to particularly the COVID-19 discussions. And what we've been able to see is that media is starting to use this list, especially New York Times, Euronews, are a few of the media channels, and we really encourage many of the media and those that are writing blog pieces to make sure that you have gender parity and diversity in who you're citing and who you're quoting and how you're informing the public, because that is a key part of really making sure we have the best solutions. Secondly, we really are talking about it is unprecedented amount of recognition of the health workforce. We really welcome the applause, but if this applause doesn't really change into safe and decent work, then we're really missing an opportunity. Women health workers are quite rightly applauded in this pandemic. Their extraordinary resilience and commitment, but we also need to acknowledge that health systems were established by men for men. And Dr. Joya just talked a little bit about that earlier, but we, from a race perspective and a gender perspective, we need to acknowledge that the default health worker is now female and that women have different needs. Women make up majority of the workforce, but they remain clustered in the lower status, lower paid jobs, mainly the front line. They also occupy most of the invisible lower status jobs as well. So we need to factor in that they're subject to more sexual harassment and violence as a result and are not part of the decision-making table. The immediate needs that we've really heard about is ensuring that safety is really addressed, particularly around communities, but also around personal protective equipment that fits women and policies that don't assume that women can actually work long shifts. They're currently on this triple burden, which includes providing care, taking on the COVID responsibility, but now also doing homeschooling, taking care of elderly relatives, and even doing further domestic work. So really keeping that in mind. And for too long, women have been the social shock absorbers in times of crisis. But when it comes to being at the decision-making table, they're not getting the seat. We know we have a 40 million health and social care worker shortage by 2030. And majority of these jobs will be filled by women, but that means we need to attract them, retain them, but make sure these are decent jobs, fairly paid, and that there really is a balance in professional and personal commitments that we're addressing. I'd like to also emphasize that this pandemic shines a harsh light on the low social value we put on women's work, the superhuman expectations, especially from women from lower socioeconomic groups who face poverty if they can't work. Although men face higher mortality, we know that women are having higher infection rates, especially on the front lines in health and social care. Those numbers show 70% of infections in Italy and Spain, where we do do have the gender disaggregated data coming in. Those infections are women. We also know that the long-term impact, especially the economic impact and the psychosocial impact, will be disproportionately affected by women. Women are more likely to have single income households as well too. And then really about the economic aspect, we know that women are subsidizing health globally. 50% of what they do in the health and social sector is unpaid, which amounts to 1.3 trillion per year. And during a pandemic, women's unpaid work, while it is vital, such as vaccinators and community health workers, they're going to be the first to leave the health system. And that's when really the health delivery house of cards that global health security depends on comes tumbling down. So we really need to think about it from a health systems perspective as well, and make sure women's unpaid health and social care work is valued, recorded, and brought into the formal labor market. And fourth, really viruses don't discriminate, but societies do. And this is really critical to some of the points made by other panelists, that we know the data here in the United States I'm in DC actually, so when you opened, you had the remarks about just the numbers here in DC itself, but the CDC has showed that 30% of the coronavirus patients are African Americans, even though African Americans only make up 13% of the population. We also know this is not complete data, and both in the UK and the US, there is data being collected, but it's not complete. Globally, data is not disaggregated by sex and gender or through intersectionality lens, and these are all things that we really need to do much more to understand the situation. But it's deep rooted, as mentioned earlier, and we need to acknowledge that how we are seeing things play out in COVID-19 is actually due to magnifying long-standing structural inequalities. And these are prevalent here in the United States, but they're also prevalent between countries, within countries, and we really need to factor this into our response, but also really think about, as we build back better, as we look at universal health coverage, that we are addressing these issues.
Thank you so much, Rupa. This is really an important time, as you've mentioned, to recognize and support our health workers. And I really appreciate your commentary about pushing the applause to action. So thank you very much. Before we shift gears, we're gonna go back to Neil, who lost connection for a bit. Neil?
Thanks, Sarah. There's nothing quite like having an unstable internet on a high-profile webinar, but I'll be pithy. I was going to provide some more specific examples from my hospital, but what I really want to say is that at this moment where the people, and we've all heard the numbers, my co-panelists said this far better than I, we heard about the numbers in DC, and Dr. Creer Perry's state, I think African Americans are 33% of the population and 70% of the deaths. The people who are being disproportionately impacted by this virus are the very people that our health systems have failed to adequately care for historically. And at this moment, when the healthcare system is making wrenching decisions, they feel that they have even less reason to trust in the system. As I'm telling people to self-isolate at home, even though they're symptomatic, they're feeling dismissed. As we're imposing visitor restrictions in our hospitals, they're feeling policed. As we're making truly, truly wrenching decisions about who has access to treatment when we don't have enough treatment, we don't have enough protective equipment, they're feeling condemned. And so we need to figure out how to work through this. I don't see a pathway forward, honestly, without it. And what I think it'll require is a few things. And I also want to underscore that all of this is challenging at baseline, and it's even more challenging now, not only because of the heightened tensions as we're seeing friends, family, colleagues fall gravely ill, but as information is just evolving so dynamically and rapidly. I will also say that all of us on the front lines of healthcare, what we're seeing in real time outpaces anything that the media can report. Or anything that the academic journals can sort of make sense of. And on a daily basis, we see things that challenge everything that we thought previously about who's likely to become gravely ill, what organ system it's going to even affect. And so we need to have humility to be able to take in new information, to be able to suspend our priors, not our values, but we need to be able to take in new information and sort of consider what we're learning. We need to have empathy, which means when people in the community or people in the health system take tough positions, we should aim to understand them. We don't always have to agree with them. Where possible, we should build bridges, and where not possible, we should be precise about where the gaps are. And then the services, as we've all said that were essential before this pandemic, are essential now. And that the resilience of any society should be measured not just in how we absorb the shock, but how we keep the essential things going. The only way to do that is to not just demand that the services exist, but to fundamentally redesign the way that we're delivering them. That's really where our attention should be. And maybe further on in the panel, I can provide some examples of what that might look like. Thank you.
Thank you so much, Neil, and thank you to all of the panelists. This was a really wonderful contribution to the discussion of gender and race in light of COVID-19. Now, actually, before we turn to the next question, I just want to remind people online, I know we're getting some questions in, but if you would like to submit a question for our panel, please submit it to mhi@wilsoncenter.org. Okay, so now I would like to move the conversation. We've already spoken some about race, but I want to move back to that and really focus in on how the current pandemic has magnified existing social and racial inequities and racist systems. And Dr. Joy, if you don't mind, I'm going to throw this back to you, considering your vast experience work looking at racism as a root cause of health inequities. So after Dr. Joya speaks, please panel, we're going to try to make this a group discussion. So just pop in and add to the conversation. Go ahead, Joya.
Thank you so much. So yeah, Neil mentioned my home state of Louisiana. And honestly, for me, that was the moment that I knew it was going to be bad, when the first 2 deaths in New Orleans were Black men aged 53 and 58. And I recognized that the narrative in the media was that it was old white folks dying, right? Or that it was the Chinese virus. So our biases showed up in how we were perceiving it and how we were portraying it. So the Black community was not prepared and was not aware that it was something that was going to be so impactful. And if we had, from the beginning, understood how racism works, we would have known this. And I love these conversations around gender as well, because gender goes both ways, right? So we pay for health insurance in the United States through Medicaid. And for a lot of states, like my own of Louisiana, you had to have birthed a child to qualify for Medicaid. So we have generations of Black men who've never had access to any kind of health coverage, who, until we got a Democratic governor 4 years ago, their parents didn't have it and they didn't have it either, right? They've been working, they cook our food, they work at our restaurants, they drive the cars around, the taxis, but they had no access to any kind of health coverage. So when the virus comes, it exploits the way that racism has racialized who receives health insurance. It also exploits the gendered norms around who does deserve it around health coverage. So if it's only pregnant birthing people, then that means it's only women. And so there are Black women in Louisiana who had health coverage, but only when they were pregnant. As soon as the baby was born, they no longer had access to any kind of insurance. And so at least for that little amount of time, if they had diabetes or hypertension, they knew then, but they don't know anymore. So you see how racializing benefits like insurance, which other countries can't even imagine that the United States would do something like that, right? But when we created Medicare in the 1960s, we did not allow homemakers or farmers to get access to Medicare, right? Who were homemakers and farmers in the 1960s? Black people, right? So we created huge systems that left out large parts of people who look like me because we believed that they were broken and not valuable. So we have an opportunity to stop doing that and to invest in healthcare for all, that believe that health is a right, to be a country that really values all ethnicities, all languages, all genders, right? And so that we can grow and thrive. So that would be my answer.
Thank you very much, Joya. Zara, go ahead.
Yeah, I want to pick up on Joya's remarks and talk about an issue that's personal to me as an immigrant and the daughter of 2-time immigrants, the unfolding crisis within a crisis that is immigration and COVID-19. So over the last 4 years, we've seen an escalation of attacks on the intersection of immigration and healthcare policy in a xenophobic, classist, and racist attempt to undermine both. The conservative philosophy behind these attacks is an exclusionary one that values people based on their current health and wealth and status, rather than on their potential or their humanity. It views health and other privileges not as rights, and government support for these needs as a drain on society, not as an investment. The notable result of these politics is the patchwork of federal restrictions that Joya alluded to on Medicaid, the Children's Health Insurance Program, and the healthcare marketplaces established under the Affordable Care Act. These have barred access to health insurance coverage for many immigrants in the United States. In part because of these restrictions, non-citizen immigrant women of reproductive age in the US are 3 times more likely to be uninsured than US-born women, 32% compared to 10%. Our patchwork health insurance system, and I use system loosely, means that just 30% of US workers with incomes below the federal poverty level are even offered employer-sponsored insurance. And many have to decline this because they simply can't afford the premium. And this problem is heightened for immigrants because they're much more likely than citizens to have low-income work and to work in industries that don't even offer health insurance to employees. Now, under the cover of COVID-19, there's a further scapegoating of immigrants and their health, but by denying financial and health relief to many people in this country. So even though the government has announced that COVID-19 testing will not be used against immigrants in the public charge test, the lack of trust that Neil also alluded to between immigrants and the government means that many people are simply too afraid to seek care. And in addition, because immigrant families are unable to access cash assistance, unemployment insurance, or other supplemental nutrition programs, or are just simply too fearful to do so, they may lack the other financial and logistical needs needed to seek out COVID-19 testing or treatment, which puts them and their families and communities at risk. And this is on top of not having access to the social safety net that they've already contributed to that would help with their basic needs, including food, housing, and a secure income. Now, I want to talk about solutions because it doesn't have to be this way. So there is progressive legislation to expand health insurance coverage for immigrants, and it's based on an alternate vision, one that values, respects, and supports people inclusive of citizenship, race, wealth, or health. As we're seeing, public policies around immigration, healthcare, and reproductive rights are inherently intertwined and must be addressed collectively, especially during this crisis. Now, there are a number of advocates working to repeal the long-standing and harmful restrictions on immigrants' health coverage that are rooted in anti-immigrant sentiment and, quite frankly, racism. One of these efforts is the Health Equity and Access Under the Law for Immigrant Women and Families Act, known as the HEAL Act. This is a bill that would greatly expand immigrants' eligibility for health insurance coverage and access to care, including sexual and reproductive health services. In addition, Congress currently has several proposed healthcare reform bills, some of which would expand health insurance coverage to all immigrants. Notably, the House and Senate Medicare for All proposals would enroll all US residents in a new national health insurance program with no exclusions for either documented or undocumented immigrants. And we see the benefits of that type of proposal now. So if you want to get involved, there are groups like the Protect Immigrant Families Coalition that have developed resources for both individuals and families who may be impacted, as well as for advocates, many of whom I know are on this call. And lastly, I want to highlight that Guttmacher will be publishing an in-depth policy analysis on immigrants, insurance access, and sexual and reproductive health and rights later today. And I really encourage you to check that out.
Wonderful. Thank you so much, Zara. And thank you so much for giving solutions, all of you. It's really, really helpful to the conversation. So I'm opening up the floor. Layla, go ahead.
Yeah, thanks so much. I think what Dr. Joya said was I like the way she put it, the different oppressions find each other. And I want to just talk a little bit about exclusion in relation to population groups who have historically been excluded and continue to be, and we see this in the COVID response as well, and we have to be careful to make sure that our approaches are inclusive. So we know that 15% of the world's population experiences some form of disability, and women with disabilities comprise 20% of that. So in terms of accessibility, just to give an example of how we think about inclusion when we're disseminating public health information, when we're thinking about accessible services, we really need to ensure everything that we do is accessible to population groups like women with disabilities. In typical, let's say, non-crisis situations, women and girls with disabilities are up to 10 times more risk of facing some kind of gender-based violence. So you can imagine when there's isolation, when they can't reach their regular caregivers, or they can't reach anyone because of disrupted routines, this can really increase. So it's really critical to ensure that our public health information and our services are thinking about them when disseminating information. I also want to talk very briefly about women and girls in humanitarian settings. IDPs and refugee women and girls face really high risk of gender-based violence, including sexual violence anyway. So in the situation of COVID, we have to be very careful to take that into consideration. We've seen from previous outbreaks like Ebola, for example, when there's economic devastation for women and girls, you can also experience sexual exploitation. And this is something to be really mindful of, particularly when we're talking about refugee women and girls who may be isolated, who may be in camps where attention, again, resources and services are diverted to deal with the magnitude of a COVID fallout. So this is really critical. And lastly, I also want to talk about Indigenous women and girls who also face higher rates of violence typically, and again, magnified and could be exacerbated in a situation under COVID pandemic. And I think it's really important to realize that Indigenous communities can be really, really significant partners in helping address the problem, especially within their communities. And I think this is a principle across the board, whether you're talking about disability or refugee women and girls or Indigenous women and girls. They have to be partners at the table, crafting the response, really there with their representative organizations. And this goes for women's rights organizations as well, as I said earlier, in terms of the gender-based violence response more broadly. And these are all issues and population groups that the UN and including UNFPA are talking about. And if you go to our website as well as the UN website, you'll see many resources, including a guidance note that was just released yesterday on engaging Indigenous populations and ensuring that their safety and security is there within COVID. And similarly for persons with disabilities, and the IASC has published a lot of materials on ensuring that women and girls who are refugees and IDPs in emergency situations are also secure and safe during this time, and being ready for the preparedness, as I said. So yeah, I just wanted to bring up some of those groups as well.
Thank you very much, Layla. Rupa, on to you.
Yeah, so just really building on a lot of what's been said, these are, again, going back to the root causes. We know particularly minority groups have much more lower socioeconomic status. So here in the United States, 22% of Black Americans live in poverty versus compared with 9% white Americans. So we know poor social groups are more likely to live in overcrowded housing, be in lower status jobs, and really also be in what we call invisible jobs as well, as far as janitorial roles, be in transport, and are more likely to be exposed. There's also the deep-rooted mistrust that has been built over centuries, as Dr. Joya really talked about, and it's currently heightened with government policies all around the world, depending where you are. But right now, conversations that I've had with minority groups, what is being shared on mainstream media as the best policy, the best public health policy, many of them feel like it's a targeted campaign to further disenfranchise them, to keep them in lower socioeconomic roles, to put greater financial burdens. A lot of the stimulus package here in the United States is very unlikely to reach the most in need. In other countries around the world, very likely there's concerns about whether the response is really going to reach the communities that are the greatest in need. So we really have to also look at this from that social determinants of health perspective, but the root cause of that, I really liked how Dr. Joya talked about that and get into that mindset. From a health practitioner perspective, also these are the same groups that are more likely to have higher rates of non-communicable diseases such as diabetes, hypertension, cardiovascular disease, renal disease, and we know that this leaves them from a biological perspective more vulnerable, and they're also less likely to have health insurance, universal health coverage. So it's almost one after the other, a multiplier effect of burdens that keep in a way keep them much more vulnerable. And then from a health workforce perspective, looking at numbers of here in the United States, we know that to address some of the bias that's already really inherent in the health systems. We really need to have people that represent and are from the communities that we're trying to reach be part of the health workforce. So in the United States, minority physicians only make up 6% of all practicing doctors. And minorities include African Americans, Hispanics, Native Americans, whereas that population is about 30% of the US population. So you can see there's a massive gap, even just in who is part of the health workforce in the decision-making roles. And so as Layla talked about, when we're thinking about what interventions we really need to make in pandemic, but more broadly from a health systems perspective, it's really making sure that we have diversity hardwired into decision-making, informing our policies, informing our interventions. And this will help address some of those root issues that we're talking about, building trust back, which is mistrust over centuries. So really see this as an opportunity to look at those long-standing structural inequalities and address them on race, ethnicity, and other aspects which have been discussed here.
Thank you, Rupa. Go ahead, Neil.
I'll just continue to build where Rupa left off, which is, and how do we go about trying to correct for centuries of well-founded mistrust? And part of what we're seeing is that the fissures that pre-existed in our health system and our social safety net are now being brought into stark relief. And the very same progressive policies that many of us have advocated for are even more important now. Dr. Creer-Perry highlighted one of the cruelest features of the American healthcare system, which is that if you have a newborn infant and you're about 2 months in, which is when you're at like peak sleep deprivation, existentially and otherwise, things are the hardest. In our country, without paid family leave, you're also trying to earn a living wage while caring for a newborn infant. It's exactly when we pull the rug from underneath you and dismantle your access to healthcare by taking away your health insurance. And through March for Moms and other work that we're doing, we're very much focused on making sure that we get public policies in place that serve the most vulnerable. But I want to highlight that what policies do is they codify the changes that we need. That's not going to be sufficient by itself. We also need the will for change in the first place, which requires empathy. And that requires a continuation of what I think is some of the best media reporting that's coming out right now, which is really telling a lot of the stories that my co-panelists have highlighted about what it's like to be an essential worker right now. It also requires not just the will, not just the rules, but really the means. And that gets back to this idea of designing services differently. One of the things that gives me hope right now is that as our capacities are being overwhelmed, in order to create new capacity, we are structurally changing things in real time that have taken centuries, or not centuries, they've taken decades. But things like, overnight, my governor decided that if you have a license to practice outside of Massachusetts, you can now practice in Massachusetts. Like, he just did that overnight because we suddenly needed that. There are CMS waivers now so that you can get a facility fee for childbirth outside of the traditional hospital setting. And Governor Cuomo actually just, as of yesterday, put new rules in place to make sure that, if you're a low risk person, you can get care outside of the tertiary center and maybe even by different people than surgeons like me, which not everybody necessarily needs or wants. And so I see a future where we not only rethink what the rules are, but we actually think about where people get care and by whom. And the by whom, to pick up on what Rupa says, very much needs to include people who look like the communities that they serve. Thanks.
Thank you very much, Neil. And thank you everyone, particularly for giving solutions along with all the issues. And now I'd like to turn it back on that again, just to dig a little bit deeper and quickly, because we are going to move to online questions, but to really kind of come back and give a little bit more on solutions for either the long-term or the immediate for either the gender or race inequities. And we'll start with Katya on this. You're muted, Katya.
Being a little polemic here, and thanks a lot. I've learned so much the last hour. And picking up on the empathy. I don't know if we look at what some of the countries that have been dealing most efficiently and effectively with the pandemic, they have one thing in common, and they let many of them, most of them are led by women. We see it in Denmark, we see it in Taiwan, we see it in New Zealand, we see it in Germany, and everywhere they have, kind of being empathetic and being kind doesn't mean you're not strong. So we have seen some of the most efficient responses there. And so if we look at long-term solutions, I'd say, let's rebuild a health system where we put empathy at the center of healthcare. I come from Scandinavia. I'm Danish, and it's very interesting to see how here in the States, healthcare is an individual thing. In where I come from, it's a public good, and we see how that deals with things differently. We need to put girls and women at the center of recovery, and they have to be elevated into that level of leadership position. I really like what Rupa said about health system being designed by men for men, but that the default health worker today is female. And we need to look at that. And it's not just, the homogeneous, here's girls and women and they all alike. We need to take the racism, the classism, and the genderism into account here. We need to put these tracks down now. I don't think we've had a more opportune time. Who could disagree in a health system being strong right now? This pandemic, it knows no borders, and we really have to both build back the health system strong, but also united. We need to collaborate. We cannot close ourselves around ourselves now. We need the multilateralism. We need the collaboration. And we need to prioritize the primary health care and universal health coverage. And it needs to be grounded in the gender equality and in human rights. And in that is also the sexual and reproductive health and rights. I know some places it's vilified, but it's part of our reality. And we cannot shy away from that. Decision makers must examine the gender-based differences in health and race differences in health expenditure, in disease detection, in response, in emergency preparedness, research, development. In the Alliance for UHC, we have an alliance for universal health coverage and gender and sexual and reproductive health and rights. We're working really hard in the international institutions and now at country level as well to get that strong health, universal health coverage. It has to be strengthened and to put girls and women at the center, also in humanitarian settings. So going back to what I said in the beginning, it's the health, it's the gender lens, it's a gender marker, so we actually track and measure what we treasure. It's the meaningful engagement at all levels of women, of young people, and in all their diversity. And it is to ring fence, safeguard that sexual and reproductive health and rights. Imagine if we could get to the other side of the crisis with, sex, age, and ethnicity disaggregated data, with more women in leadership, with the proper recognition of unpaid care work, of health workers. That would be not only a stronger health system, it would be a much stronger society, and we can put those tracks down now.
Thank you so much, Katja. We're going to shift gears now because I've been pinged that we have many, many online questions and time is running short. So I'm going to turn things to my colleague, Dikshita Ramanarayanan, and she is going to give the panel one or two questions, and please, chime in with your responses, and we'll try to keep them short and concise so we can get through a few questions before we do our closing remarks. Go ahead, Dikshita.
Sure. So I'll start off with two questions. First, what are you seeing in terms of the mental health repercussions on women and minority communities, and what can we do to address this? Second, I think earlier Katja mentioned partnerships such as Deliver for Good. Given government's financial constraints, could you and other panelists expand on the potential for partnerships with the private sector, both in the crisis and recovery stages, and how these partnerships can be rebalanced to give women a voice?
Great. Okay, so first on mental health, maternal mental health. I think it's actually Maternal Mental Health Awareness Week next week. And then the next one is on government and expanding partnerships with private sectors and others. So who would like to jump in first?
Okay, I'll go if nobody else
Great.
does. Just about the maternal mental health, that we are seeing that birthing people across the United States for sure are nervous, they're isolated, they don't have a lot of information, and we already underdiagnosed both pregnancy, postpartum depression, and postpartum anxiety pre-COVID-19 in this country. We didn't have an infrastructure for mental health, and so many birthing people would go home without support for their mental health. And so now we're exposing even how fragile that is. As a Katrina survivor my own self, I know we are going to have a world that's going to have PTSD after this. And so we know birthing people who had imagined that they were going to have people in the room with them, that they were going to celebrate, they were going to have come home and have grandma to cook and have family members that come over. None of that's happening. So people are grieving the loss of what they perceived their birth experience would be. And in that grief, they are traumatized, and we really don't have a structure to help them walk through that. So we are nervous around long-term what this will mean for birthing people during this crisis.
Thank you. Go ahead, Rupa.
Yeah, so I'll take a chime in into the partnership aspect of it. And I think there really is an untapped potential that we can do even much more when it comes to working in a partnership aspect. I mean, turning to the World Health Organization, they've done a fantastic job of trying to bring as many actors together to various aspects of the response. If you take a look at how they are trying to connect with communities around the world, very strong work on communications, bringing in FIFA to celebrities to community voices. So that's really tapping into the trusted voices locally to disseminate key public health messaging. The second example that I'd like to share, which is a very tangible one, is the Accelerator has been launched by WHO, which brings about 8 partners together to look at vaccine development and other diagnostic tools that can be accessible in a more cost-effective way. So we really do need to think about how some of these larger initiatives that are being launched by UN agencies such as the World Health Organization hardwire issues of gender, broader equity, access, and financial protections. And I'm sure Katja will have more to say on partnerships since we do co-convene an alliance on gender equality and universal health coverage, which brings 110 organizations that are really putting forward globally the call for universal health coverage to really have a women's rights and girls' rights perspective.
I just want to pick up on what Rupa said and highlight that the fact that the WHO is a force multiplier. That's why it exists. It's a catalytic investment for countries. And so I think investing in the WHO and all of the UN is particularly critical at this time. I would also say, as much as we want the private sector and NGOs and others to be involved, it's about being coordinated. And there are a lot of bodies that do this. We shouldn't all just go off and do our own thing. I'm coming from the CDC previously, and there are groups like the CDC Foundation that help streamline investments so that we aren't duplicating efforts. There's so much goodwill out there, but we need to harness it for the best.
Thank you. Go ahead, Neil.
I was just going to highlight that there's a tremendous opportunity for the private sector to get involved alongside governments, particularly in the US, where we have a number of corporations that are the size of the GDP of entire nations. I'll point out that some large corporations in our country, some of the largest, Walmart, Amazon, because of the way our private insurance system works, actually purchase more reproductive and childbirth services than entire state governments. Like there's a Walmart baby every hour. They have tremendous purchasing power. Many of those companies like Amazon and Walmart are actually seeing their profits go up at this period by considerably as people access them for supplies. And they could use their purchasing power. Similarly, in our private insurance system, they're not paying for services that have been suspended, and they're seeing cash surpluses. And they have a really critical role to play in the recovery as well.
And we in general see, this is everybody's business, and it cannot be business as usual. The collaboration across sectors, but also across issues, is absolutely key. If we only treat this as a health emergency, we're missing the point. So we both need the private sector, and we need the civil society, and we need the multilaterals, and we need the healthcare workers. We need everybody on this. And yes, coordinated effort is important, but more important is the mindset change. That's both around the collaboration, but also how we see gender in and across this. I'm seeing some great new initiatives. We're seeing people who are advocating from deep within the systems about gender disaggregated, about the different lenses we need. And I'm very encouraged about that. It just needs to be fast.
Thank you. Go ahead, Layla.
Yeah, just to say that I think the private sector does have a tremendous role, particularly if you're talking about supporting working parents in terms of paid leave, in terms of flexible working hours, these kinds of things that we know disproportionately impact women, as we've talked about. So I think, and including what Neil has said, I think there is a big role for the private sector, both in terms of also leveraging resources, but also bringing attention to these issues around gender inequality and discrimination within COVID, because they've got a wide reach. But I do want to emphasize the role of the state, and this is really becoming so very clear in the COVID response, preparedness, and recovery. So we need to ensure that social protection packages are really taken into consideration, that there are gender-based inequalities, and that women and girls really are at the center when social protection packages are being crafted. And I also want to say on partnerships, the UN system is really coming together in a way that is binding us, and that includes across the nexus of development and humanitarian fields, which is very interesting and very encouraging. So can't say enough about, as Zara said, ensuring that we're all working in a coordinated manner. This is really important, particularly when we need to have real-time response and quick responses.
Go ahead, Rupa.
So just, I wanted to also reflect upon the mental health question and say that we really need to keep in mind the mental health of our health workers as well. We know from previous studies that have looked at both Zika and Ebola that health workers that have been part of the pandemic response or disease outbreak responses in the past carry not only mental health challenges and burden while a crisis is happening, but post as well with PTSD that's specific. So it's really important that when we are looking, and this applies to private sector and anybody that is really working with the health and social workers, that we have deliberate interventions and plans to really support the mental health and psychosocial aspects of it. Thanks.
Thank you very much. And we are almost out of time, so we're going to do a quick lightning round for all of the panelists to just give 30 seconds, just 30 seconds about, given our conversation today, what you personally are going to take back to your organization or do yourself in relation to our conversation. So 30 seconds, everybody. Go ahead, Katya.
Great. I have a message, an ad, and a tweet for you. First, a message. Use your personal and professional power in your institutions to make sure that gender is at the center of what you do. Get out that gender lens, put on that gender marker, and protect the health services, including sexual and reproductive health and rights. The ad, join the 600 plus organizations and sign on to the Deliver for Good call to action to the world's decision makers. You can find it on www.deliverforgood.org. And the tweet, use the gender lens, put gender at the center, create a new and better normal. Hashtag COVID-19, hashtag just do it.
Wonderful. Who's next?
I'm happy to chime in. I just love the energy of just do it. So 3 takeaways here. We must build back gender responsive global health. Universal health coverage reaches everyone. Second, this is not a gender war. If we enable women health workers with decent work, they will deliver better health systems that benefits all genders, including men. And really, we don't need to ask permission. Everything we're asking for has already been agreed by governments in the Sustainable Development Goals, in the Universal Health Coverage, a high-level political declaration. And really, my call to action is that we really need high-level political leadership at all levels that's coordinated to really build back better gender-responsive global health.
Sarah, you mentioned Black Maternal Health Weeks. I just want to highlight that we just have a Black Mamas Matter Alliance has folks on the ground with answers and solutions. So if you go on blackmamasmatteralliance.org, you will see folks who have been creating solutions that we could uplift and highlight, doulas, birth workers, midwives, OBGYNs like me that are really working for Black maternal health.
I just want to say that the post-pandemic future and building back better really shouldn't come at the cost of ignoring important gender equality and human rights issues. And I would say my key messages, and this includes for myself personally, but also my professional life, the time is now really use this opportunity to talk to, in your personal life, your family, your children, your friends, and professionally your colleagues about domestic violence, about gender-based violence. We see it in the media, we see it being talked about more and more, and I think this is an opportunity that we didn't have before on a global stage to really take back the message that we can build back better, and we can work with children in early socialization, including comprehensive sexuality education, to really teach respect, to teach equality, and also, very importantly, to teach consent. So I would say use this as an opportunity to have those conversations with your family, with your friends, with your colleagues. And yeah, thank you.
Yeah,
I'll just say,
I want to say that sexual and reproductive health and rights are not just about women or girls, it's about everybody, and it benefits everyone, and it's everybody's business. And I want people to take that away. I also feel called to seek out and uplift the voices of marginalized communities that we haven't talked about. So we haven't touched on HIV positive people, LGBTQ communities, youth, the homeless, to seek out those voices, raise up their stories, and more importantly, to talk about the solutions that they want, the future that they want when we do build back better.
And I don't have very much to add. We've talked a lot about leadership, but I just want to amplify the prior comments about allyship. That includes amplifying the voices of marginalized communities, as Zara just said, and it also includes, I think, male allyship, which is critical, especially as we talk about gender-based violence.
Thank you. Thank you all so much for this incredible panel and discussion. I feel very, very optimistic, and also I'm sure our viewers have really learned quite a bit. I know I have in this last hour and a half. So thank you again to the panelists, and also thank you to my Wilson Center colleagues, especially the Maternal Health Initiative team and the AV team who made this such a smooth online transition. I'd also like to thank our partners at EMD Serrano. Post-event, we'll produce a summary and a podcast from today's discussion, which we'll share with everyone who is watching online. In addition, we'll also be producing a podcast with global health experts, including Dr. Felicia Knoll, to discuss how the COVID-19 pandemic is affecting women with existing non-communicable diseases. So thank you again. Thank you everyone for joining us today, and please stay safe.
Thank you.
Thank you.
Bye-bye.
It was fun. Go team.
Thanks.